Hi, everyone. Thank you so much for joining us today. We're really excited to have you here, and thank you again for everybody's patience and understanding when we switched the date with this one for you. We wanted to make sure that everybody had the opportunity to attend the NAMS webinar that was going on at the same time as our original time and date. So we really appreciate you being flexible and joining us here today so that we can talk about building a COVID recovery plan with both Joni and Sharon. So I'll walk through the agenda really quickly, introduce our speakers, and then I will hand it off to those speakers. Just a couple housekeeping things in the meantime. You are all currently on mute as usual, but that doesn't mean you can't interact with us. Feel free to either use the chat function if you need something immediately, or if you have a question for the speaker, you can use the questions function, and we will try to have time for Q&A at the end. However, if we don't quite get there, if we have a lot of content to cover, a lot of great content, so if we're not able to handle that in a formal Q&A session in this webinar, if you still submit those, we will get back to you via email to answer those questions. So today's session, our agenda will focus on three main areas. The first is, why do you need a recovery plan? Why is that important? The second is, what factors should you consider when you're creating this recovery plan? And the last is how to configure or how to evaluate virtual medicine, connected health, and how that should figure into your plan. Our speakers today are Joni Arand and Sharon Beckwith. Joni has 30 years in healthcare, both in the managed care environment and the hospital environment. She is a senior solution manager for quality at Simpler, and she's really an expert in all aspects of provider management and quality improvement initiatives. If any of you have had demos of some of the Simpler products, you've probably been introduced to Joni that way. She has her degree in corporate communications and minors in interpersonal communication and international studies in communication. She is a certified trainer, speaker, coach. She really loves the education component of her job and supporting our clients and making sure that they are developing quality improvement plans that are integral to their organizations. I'd also like to introduce our second speaker, Sharon Beckwith. Sharon is the CEO of MD Review. She has 20 years of leadership experience, and that comes from a unique combination of both executive management, but then she has special expertise in both physician peer review and medical staff management. So she works on a daily basis with hospital clients. She helps to understand their medical staff, quality improvement, risk management, and any challenges that they might have with peer review. She has a lot of great speaking experience with Medical Staff Services Organization. I think I just heard she's going to be speaking at one of the regional NAMS conferences coming up here, as Joni is as well. And so without any further ado, I'll go ahead and pass it over to Joni to get started with our presentation for today.
Thank you so much, Alex. I appreciate it. Hi, everybody. That is me on the left, for those of you who don't know me, and my granddaughter, Lainey. So she wanted to be in the presentation, so we took our picture with our COVID mask that she thought was really cool. So that's us there on the left. So I just want to start out by saying today that, you know, Sharon and I were talking about this a couple days ago, and we had planned to present this, you know, a few weeks ago, and we had to change the date because of the NAMS presentation. So what's interesting and fascinating to me is that in a month's time or 3 weeks time here, really, things have changed again. So this COVID-19 is changing daily, almost weekly for sure. So today our goal and purpose in this is to help you think through some considerations in planning your strategy for COVID-19 recovery, hopefully. But when we use the term recovery, it's kind of iffy right now, because when are we going to recover? What does recovery mean? Does it mean a vaccine? Does it just mean that we're trying to hold our head above the water? I mean, what does it mean right now? So that even in itself, that term recovery is kind of ambiguous right now. So I wanted to say that and kind of preface this by saying that Sharon and I, neither one claim to be experts in what you should be doing for a strategic plan for recovery from COVID, but what we would like to do is share with you a lot of the things we're hearing from the experts in the industry, as well as from our own customers and clients that have their plans that they're working on and what they're going to include. So I think we have a lot of knowledge coming from different sources that we can share with you today. So we know now that COVID-19 is our new normal, so to speak. So let's just move on and begin to talk about why we need a recovery plan. So as you can see here, we have been here before. The trouble is, none of us are over 100 years old on this call, I don't think. If you are, congratulations. So we could probably learn from you. So in 1918, of course, we had the influenza, and everybody did, resort to mask. And I think I love these pictures because it just shows you that they went on about or tried to go on about their daily lives with their mask on, just like we're trying to do. And a lot of them were quite spiffy in them there on the left. So we've certainly been here before. This is not something that has just come out of the blue. It has happened about 100 years ago. And then also, we're most likely to be here again, or we may even just stay here for a while. We might just camp here with COVID-19 for the next 6 months to a year, which we didn't really expect. I found this fascinating. This came across one of my reference sources that I was looking at, and it said in 1962, an Italian magazine did a story about what they thought the world would look like in 2022. And I found this really interesting. It's almost like they had a premonition here. So they drew this depiction of what they thought the world was going to look like in 2022. And we may be getting there. We may have to isolate from one another in every way, shape, or form. So I thought that was pretty cool to include to show you all that. Now, let's just kind of start with, again, the why. Why do we need a recovery plan? Well, the prediction around the 1st of May, end of April, was that, we estimated that there's probably going to be about a $36.6 billion cost or financial impact, net cost or financial impact to our hospitals over a 4-month period. We expected COVID to be ending after a 3 to 4 month period, by the way, then. So in other words, all the hospitals and health systems would collectively lose $36.6 billion was the prediction there. However, those were just predictions. So the U.S. hospitals are losing millions of dollars per day in the midst of the COVID-19 pandemic, and recovery may take years, was published on May the 5th. And most of the news organizations agreed. So HFMA did a survey, and they started asking those hospitals around the 1st of May what they thought was going to happen. They surveyed 500 healthcare systems and physician offices and healthcare organizations. 174 of them did respond out of the 500. Most of them were director level there on the left. 50% were directors, 40% were C-level, and then 10% were vice presidents. And as you can see here on the right on the graph, most of the responses came from the hospital sector or medical centers there. But a lot did respond, which was good. So what did we learn from that? Well, they asked them a question. How do you expect your future revenues to compare to your pre-pandemic revenue levels? So as you can see here, in the middle there, 42% expected 15 to 30% loss there with their revenue levels. And then there on the right, it said compared to COVID, 89% predict their organization's revenues will be lower at the end of 2020. And then among respondents, almost 2/3 of the product decreases of greater than 15%, and 1 in 5 forecast decreases of more than 30%. So we're smart enough to know that our revenue is going to drop dramatically as a result of this. So that's a given, which is good. So now what? So this is why we need a plan, of course, because if the revenue is going to drop that much, then we need a plan. Now, this is actually the reality as of July. U.S. hospitals and healthcare systems are now projected to lose $202.6 billion over 4 months by AHA. So these numbers just keep going up. The actual April losses among the more than 800 hospitals included in the Kaufman study or finance report were describing it as devastating. So April findings included a 174% decline in EBITDA margins, 118% decline in March, 282% decline year over year, and so on. So these numbers were pretty devastating around April and May. April was actually the worst month ever for hospital finances, according to them. We're in a perilous position, and to me, when people are using this type of terminology, devastating, perilous, that is just a huge wake-up call to the fact that we better be looking at this. We better be planning. We better have something in place to know how we're going to handle this moving forward. But I want to be a little positive today and hopefully encouraging and uplifting. It is not all bad news. There is some things that we can do to start to recover and start to plan to recover. So that's I want to be a little bit positive as much as we can here. So let's talk about that. So I think in your plan, you want to accentuate the positive, and I'll talk more about this as we walk through these points. Some of the steps that we might want to consider in your plan need to include some positive messages and positive things that we can do that don't cost money, that wouldn't, decrease our revenue anymore. As you're putting together a recovery plan, these are some of the steps that I would like you to consider. And again, these have just come from all different kinds of sources of people who are currently doing theirs, as well as some of the experts that we have access to in Symplr. First and foremost, try to establish ownership. Who is going to be responsible for each step of your recovery plan? Is it department chairs? Is it nursing staff? Is it the CEO? I mean, who's responsible for what parts of this recovery plan, and who has ownership of what we're going to be doing and how we're going to be doing it? So that's first and foremost. Don't get confused on, well, we thought this department was doing it, or we thought they were doing it, or we thought they were responsible for the cost, or we thought they were responsible for this or that. So establish that ownership. Secondly, establish target audience. So you want to make sure that you kind of narrow that down to measures, margin, metrics, what makes sense to whom. So make sure whatever you're going to be tracking or reporting off during this makes sense to the person responsible for that in the plan, and make sure that they have access to that information so that they can plan. Then it's really important to choose a name for your recovery plan so that everybody in the organization knows what the name is and what the name of the recovery plan is. So they're familiar with it. They know they're a part of it. They know it's happening and going on. And the more your marketing areas or other folks in the hospital can help you with that and kind of get the word out, we have this new XYZ recovery plan we're doing. Here's the name of it. We're all going to be a part of it. And don't think it has to be something real business-like. The name of your recovery plan, maybe make it fun. Maybe make it something that everybody would, funny, something that everybody would like to participate in, and it be encouraging. Don't just focus on cuts. Your staff is going to get depressed if your entire recovery plan involves cuts in budget, cuts in staff, cuts in this, cuts in that. Make sure it's balanced. Don't just focus on that in a plan, even though we do have to cut a lot probably, but try to include some positive things in there as well. Elicit some new ideas. Include a plan that works in different scenarios. Now, this is important. I want to stop here and hope you heard me say that, because we don't know, right? We don't know what's going to happen tomorrow. We don't know what's going to happen next week. This thing is crazy. We've never experienced this before. So in your plan, make sure that no matter what happens with COVID, your new plan is going to work for what you're trying to accomplish. So if it gets better, great. If it gets worse, awful. If we have a new virus come in the middle of it, what happens then? So make sure every scenario in your plan works regardless of what happens. You want to communicate from the top down. This is critical. If you don't have ownership and buy-in at the very top, and those top VP CEOs, those folks at the top are not embracing this and positive about this, then nobody else is going to buy into that. So make sure that it's communicated from the top down, the importance of it, what's expected, and so on and so forth. Incentives for ideas used. Work with your community. This is free, guys. This is free. No money here. I went into my local pharmacy a few days ago and I thought, this is so good, I can use this in my webinar. I walked into the pharmacy and there was a sign on the front door and it said, don't forget to see your doctor and don't forget to go to the ER if you have an emergency, and please make sure that you're keeping up your regular appointments, surgeries, and so on. So the pharmacy isn't the hospital and the pharmacy isn't the doctor's. I mean, but they were working with the hospital and the physician offices to encourage people to see their doctor right now and to go to the ER if they have chest pains and not be afraid, or to have their surgery scheduled again now that we're opened up for those, and so on and so forth. So if there's other areas in the community, your health centers, your community health center, your doctor's offices, your pharmacies, where you all can start to work as a team to educate your community that it's safe to go to the hospital, it's safe to have my procedures done, it's safe to go to my doctor, this will increase your revenue. So think of ways to work with each other as a team in the community. Even I had one of our customers say the other day, they're working with the schools and the teachers to encourage the kids to come in for their checkups and everything, even though they're having virtual school here in Tennessee where I live. So, but they're still at the school encouraging them to go to the doctor's office and get their checkups and all that. So again, just anything you can do in your community. Review current, and I put old there because some of them are old, depending on your organization, policy. Does your current vision and mission and your business model still make sense? So if your hospital's mission, says XYZ, has that changed with COVID? Do you need to change that mission statement? Do you need to change your vision statement? Do you need to change your business models? And certainly your policies and procedures. I want to compliment all of you on the phone because I'd say 99 or more percent of you already have great policies in place, wonderful bylaws. You were prepared for this. You all know that this is what you do. So for the news or anybody else in the industry to say, oh my gosh, hospitals aren't prepared, I'm like, y'all are crazy. Yes, they're prepared. That's what they do. And I commend you for that. So yes, you were prepared. Yes, you have infection control in place. Yes, you have policies and procedures and bylaws in place, but what we need to look at is, did they work okay? Do we need to change them in any way in our new plan? Transparency, what must we stop or start as a result of this? Maybe some of the things that we used to do, we have to stop for now and focus on something else. So have that transparency with each staff member, each department, and so on. If you're managed care, you need to be doing these things as well. If you're physician offices, I know we have different entities on the phone, so everybody should kind of take a look at this. Community resources, should the hospital be the first resort for patients? Try to educate your community on that. Have them go elsewhere during this virus if they need to, the urgent care or whatever for the testing, or should they come to the hospital, and try to communicate that so that you can drive the business where you want it to go. And then I just want to kick this in. I don't know if we have any rural health folks on the phone, but this is a real positive to consider in your plan. You may benefit from this and probably will, because I know, especially here where I live, all the rural hospitals were suffering before COVID. I mean, they were closing them down. It was just a lot going on with rural health. And now I'm hearing from a lot of our rural health customers, guess what? This is actually benefiting us because we have telemedicine visits going on. We have virtual medicine, so they don't have to drive 20 miles to the hospital. We can do a lot of things without them having to get in their car. So this may actually, in the long run, kind of flip the switch here and benefit rural health more. So just take that into consideration if you're rural health in your plan. How does this actually help you as a rural health facility? Okay. What are some other things we might want to consider? Of course, we have to consider cost. Cost reduction is more amplified now. It's just something that we have to deal with and we have to do. So where can you cut the fat, cut the cost? That should be in there. Ask your teams, by the way, let them participate in that and maybe even provide some incentives there. If you can find a way to cut costs, you get a half a day off work. Or if this team can find the most ways to cut costs, we're going to have a pizza lunch or leave early, whatever. Because your staff probably knows more about how to cut costs than you do if you're a director, manager, or C-suite level. They're on the front lines and they see a lot of waste or whatever's going on. So they might have some really good suggestions there. Again, the structural changes within your policy. Look at the structures of the policy and any changes there. Also, just to be real positive, you want to also include in your plan what went well. What did you do well during this COVID crisis? Don't forget to document that. Don't forget to track that, because that will benefit you in the future with value-based payment. So as you start to get paid for COVID and these things, if you can demonstrate, yes, we went above and beyond with this measure, or we went above and beyond with this service, and Hospital C down the street did not do that. These payers are going to look for those types of incentives for you as you come through COVID. So anything you can track that's going really well. Not only that, but just for staff uplifting, this is what we're doing good, guys, hang in there. So revenue and patient volume drops, of course, we have to look at that in our plan. How did the patient volume drop? How did revenue drop? And then how are we going to try to recover from that? Keep in mind, federal funding may not be enough to cover your COVID-related costs. So we know that probably won't. So how are we going to make up for that in the plan, or try to make up for that in the plan? Immediate versus long-term cost reductions. There's kind of three areas that keep coming to surface here: capital expenditures, labor, and purchase services. Those are probably the top three areas that you can look at to reduce your cost. Then finally, digital, service line, and revenue cycle seem to be the top three areas of opportunity. Not, on the flip end of that, to grow and gain more revenue. So you might want to take a look at those three areas in your plan and see if you can't grow some revenue there. And that digital includes telemedicine. Last but not least, and I'm going to run through these pretty quick for time's sake, but you don't want to leave out your staff and your patients and how they're feeling in your plan. So there needs to be a component of the plan that addresses the mental health, the emotional stability, the overall feeling in your organization and in your community. So there are very high levels of public anxiety about their employment and their own health right now. What can you do in your plan to calm those anxieties, or to be the source of truth for these people, and know that my hospital is making me feel calmer. My hospital or my healthcare organization is helping me through this. I don't feel as anxious now because of what they put out or what they said. So include those kinds of things in your plan. That will also benefit you in the long run with those incentives from a value-based reimbursement with patient experience and patient satisfaction and things like that. Include any challenges with virtual medicine and social determinants. Kind of consider these, and what I mean by social determinants is, do your patients have cell phones? Do they have computers? Can they use a computer if they're elderly? What can we do in our plan to make sure that our virtual medicine is successful? And how might we work with organizations in our community to make sure that they have access to computers? One of the things we're doing here in Nashville is the senior citizen centers are allowing the seniors to use the computers there and help them with any virtual medicine appointments they have or telemedicine appointments during COVID. The nursing homes can be your friend here. Nursing homes have computers. Nursing homes have tablets and iPads. So if you can work with your hospice or your home health or your nursing homes or your assisted livings for telemedicine visits, and if more will do those virtual visits as a result, then that's more income for you. So definitely look into those areas in your plan. Widespread concerns about co-payments and private insurance due to layoffs and furloughs, well, that's just a factor. So anything you can do to work with your patients about waiving those for a month, or just not, working with the payers to say, how can we waive those co-payments until, September when COVID's over? What can we be doing to help our patients come in to see the doctor? I know it's strange, but there's a lot of people that don't have $20. They don't have $30 right now. They don't have $50. So they're not coming to your hospital or your doctor's office or your urgent care. They're not doing it because they have to pay a copay. So what can you do to assist with that so they will come in for their visits? Continuing reports of pharmaceutical and medical supply shortages, that's just something that you're going to have to take into consideration in your plan. We may have shortages moving forward again, and what are we going to do if we do? How are we going to work around that? Unprecedented adoption of telemedicine, which we're going to talk about in a minute, but your primary care physicians, PCPs, all of them are dealing with this. So how can you all work together, the hospital, the primary care physicians, the urgent cares in your area, to do these telemedicine visits? Many hospital brands tarnished by staff layoffs, pay cuts, and safety issues. This is something that's going to be in U.S. News and World Report. It's going to be reported through the media. Your marketing department may want to take a look at that. How are we going to handle if our star ratings go, or if we get bad press, or we're going to have to do layoffs in the community? What can we do to help that staff that we might have to lay off? What are we doing to give them a recovery plan in that process? How can we help them with their rent or with what they need if we have to do pay cuts or layoffs? So be thinking about your reputation there, even though you have to do some of those. What can we do to help our staff through that? Worrisome forecast of COVID-19 this summer and fall. We keep hearing second wave. Is it going to be a big second wave, or is it actually just migratory and we have more testing now? So plan for that in your plan. If we do have a huge second wave, how are we going to handle it? Or even if we have a new virus. Don't neglect ministry, spiritual needs, mental health needs, both with your staff and patients. One of the things I heard one of our payers say the other day is they're going to incentivize their network providers if they provide mental health or spiritual avenues for the patients during this. So that might be an area too that you could capitalize on there. If this hospital is doing it and the other one isn't, then that's certainly going to bear well for you. The better I feel as a patient when I visit you, the better my patient experience. So the more you can comfort me in your plan, the more you can give me resources in my community to help me. The more you can give me direction as to what I should be doing with me and my family, the more you can support our schools, the more you can do things for me, the better I'm going to feel as a patient in your plan. Okay. Now we want to talk about quality briefly. I know there's a lot of quality folks on the phone probably. Just some considerations in tracking quality. How well did your ranking system work, and how can you demonstrate it in the aftermath? Time to impact ranking scores are important regarding decision making for quality. Certainly readmissions in your OPPE reporting, did those go up or down? Increase in your telemedicine or virtual visits, how are you going to track those? How are you, the observation at home health and hospice and so on, how are you going to track your telemedicine? Reimbursement certainly hasn't caught up. There's no playbook for that. We don't know for sure how we're going to be reimbursed or what's going to happen, but we do know that whatever you can demonstrate is going to help you. So you're going to hear me say that word over and over: demonstrate, demonstrate, demonstrate. How are we going to track our measures? How are we going to track what happened between our policies in place and our bylaws? Because you're going to, in the long run, be able to collect more money if you can demonstrate things. Reduce your complication codes, certainly. with your OPPE reporting. If you've been able to do that, then be able to demonstrate that. Always, always track the good. If you have a calm, confident, coordinated approach to care with this COVID, show us, tell us about it. How are you doing it? How are you going to demonstrate that? Certify a unit safe. How are we going to know that it is? So that's your patient safety areas. Be able to demonstrate how you made a unit safe, and if it is, and if so, how did that work for you? CMS have left it to you, pretty much, the states, to figure out old guidelines are not sufficient right now. I mean, CMS has basically said, we're going to be look at this. We're kind of giving you a reprieve for now. Same thing with Joint Commission and others. But essentially, they're still going to ask you, you know, in the long run, how did you figure this out? What did you do? And what worked well and what didn't? And how do you plan for it not to happen again, if so? The hospital must decide how to demonstrate your new plan in place and outcome. So the good news is nobody's really making you do this any way or shape or form, pretty much. I mean, you are in charge of your own recovery plan, which is a positive. So you can decide how to balance it, how to make it look right, how to demonstrate things, and so on. These are just a couple more considerations. Codes and procedures in your OPPE for COVID. Include those COVID measures and codes. I know it's simpler. We have those in place in our quality products already for you to choose from if you're a simpler client. So those are good. Your FPPE for cause should include COVID. So if you're doing focused evaluations on your providers, include COVID performance in those. Include the patient experience during COVID in inequality. How did the patient fare during this? Virtual peer review is more and more and more important. We can't have donuts and meetings right now in a room all together. We're not supposed to be doing that really. So, you know, things are changing in the way we meet, in the way committees meet, in the way we do things. So any virtual meetings or virtual peer review and things like that should be considered. How can we do that and how can we do it better? Anticipated changes in peer review. Peer review may change some, and I'm going to let Sharon talk about that in just a second. How we might have some anticipated changes in the way we do our peer review as a result of COVID. And then we want connected medicine to be included in quality considerations, and virtual exams. That's a huge category. How are you doing those virtual exams? Do you have measures that you're tracking with them? Do you have policies in place for those virtual exams and so on? Okay, so with that said, those are a lot of the considerations. You'll get a copy of this. Feel free to use them, not use them, but hopefully they made you think a little bit. I hope there was 2 or 3 and 4 considerations in there that you hadn't thought of or that might be helpful to you all. I want to kind of switch gears because really virtual medicine has become a workhorse right now, which we did not expect. I had a customer I was talking to the other day. He was the CIO there, and he said we have gone from about 3 to 10 virtual visits to over 100 a month. I hear, you know, we've gone from 30% virtual to 80% virtual. So this has become a workhorse that we did not expect. I mean, virtual medicine, telemedicine's been around for a long time, but that was usually for, you know, maybe radiology or certain specialties. You know, I talked to a behavioral health client the other day, and they were telling me, I know everybody thinks behavioral health is just so used to telemedicine and we got it going on. And they said, we've never used telemedicine. They've always come in for counseling or whatever. So he said, you know, they're always like, oh, you're behavioral health, you got this down. And he's like, no, we don't have this down. So, you know, I know that there's the perception that some specialties have had this down for a long time, but some don't. So, and then certainly everybody else has had to be thrown into it. So we've kind of got a Band-Aid solution with telemedicine going on here, and a lot of artificial intelligence in the way we're communicating things and talking about things. So I'm going to hand it over to Sharon now and let her walk through some of the changes with this virtual medicine and how we're doing peer review around all this. Sharon?
Perfect. Thanks, Joni. Yeah,
You're
absolutely.
welcome.
I'm going to talk a little bit about some of the changes just to peer review in general, but you know, a few things just sort of come to mind as I'm listening to you talk about these plans. And I think one thing that's so important, you kind of touched on it, is your plan has to be fluid. right? Because things are changing so quickly for us. You look at, like we said at the beginning, a couple weeks ago, what the state of COVID-19 looked at like then and what it looks like now have changed pretty dramatically, especially in some certain states. And so I think that having a fluid plan is something that's going to be really important. I think hospitals are really faced with some very difficult challenges right now. And one of the new challenges that they have is this whole idea of, now how do we get back to resuming elective procedures? We can do elective procedures again. Some of the bans have been lifted in most states, but now the costs for surgeries have gone up, and there's all new processes in place. And so I also think one of the most important things is documentation as we go along. Document what your guidelines are, document what your protocols are. Things keep changing. I feel like, definitely by the week, but sometimes almost by the day. You look at CMS and what their regulations are. You look at even things like PPE and how long it can be worn, and all those guidelines have changed so rapidly during this whole time. I know I talked to one client who said she's got a giant binder because she's literally documented each time they've had to change their protocol or their process based upon a new guideline that's come out, so that if and when they get surveyed, they can show, well, at this time this is what the guideline was, and this is where we got it from, and this is what our protocol said, and now it's changed, but at the time frame that you're looking at, this is what's in place. So I think that just keeping really solid, good documentation as you go along is super important as well. So I'm going to talk a little bit just about how COVID-19 has impacted peer review, and then we'll get a little bit into telemedicine as well. Certainly providers are feeling a lot of stress. You've got nurses and physicians that are on the front lines, and they're getting fatigued due to got high volume of patients. They're working very long hours. They're often dealing with very high acuity patients. Sometimes your providers that are working in unfamiliar facilities or units within the hospital have been transformed. So maybe what was a surgery unit before is now transformed into just handling COVID patients. So they're just working in unfamiliar territory. And all of this can lead to patient care errors, naturally. So I think that monitoring of performance metrics and outcomes during this time is even more important. We've got to, maintain and keep track of everything. Quality and patient safety is still kind of the trump card, right? It's the most important thing. And so we've got to make sure that even though we're dealing with a totally different type of patient base, and we're being caused to really focus on this virus, that we've got to maintain our customary quality programs still. So again, I think the initial stress, and this statement has almost even changed in the last few weeks, because we say, while the initial stress of COVID may have passed, it's obvious to me that we're going to continue to see it for the foreseeable future. And now you can see in the last couple of weeks where different states have now dealt with spikes that they hadn't seen before. States that maybe hadn't seen very many cases, they've got a large number of cases now. So I don't think it's something that's just going to go away. I think it's something that we're going to have to deal with ongoing. So the challenge is just, how do we do that? And certainly during this time, we've seen regulations have been loosened. Joni was talking about the regulations from CMS, how those have been loosened. They've sort of left it to the state or the local facilities to be able to manage that. So many people have to kind of put things to the side, if you will, and put things that, postpone them, whether it be a regularly scheduled meeting or something like that. Just put it to the side until we can get through this. And I think now it's really important that we get back to what were our previous processes. And if we've loosened regulations in certain areas, that we get back to tightening up those processes again. So I think really careful attention to just our regular, again, our quality, our safety, peer review, the whole credentialing of process. Again, it just continues to be super important and just as big a priority as it was, prior to COVID. So what's really interesting is I think if you look at quality metrics and what you can track, and Joni, you were talking a little bit about this and you know what you can track within the systems, and I do think that it might be interesting to sort of separate out your COVID patients. Oftentimes COVID patients are much sicker, they're in the hospital longer, they're using more resources. We know that the use of ventilators with COVID patients has skyrocketed. They're on ventilators for a much longer time than you would typically anticipate a patient being on a ventilator. So if we keep them sort of as part of our whole patient population, the data is skewed, but it's certainly explainable. So I think that there's this opportunity to isolate those patients and trend against that specific patient population, and then keep your other patient populations sort of separated so that you can track those measures and you don't see this very skewed data that you're trying to analyze and figure out. And I think something else that we need to just be aware of, and maybe this is part of your recovery plan as well, but I do think that we are unfortunately likely to see an increase in litigation and lawsuits, right? As a result of COVID and the exposures. Those may come from staff, from nursing staff, from physicians. It may come from patients. If they've had a loved one that has passed away due to COVID, are you going to have people that come back and say, well, was their treatment appropriate, and do I have grounds to maybe get money from the hospital for how my dad or my mom or my cousin or whoever was treated? So I do think it's something that we need to think about and we need to have a plan for. And again, documentation. It's so important to be able to defend yourselves against any lawsuits that may come up. If you have documentation about what you've done during COVID and how you follow guidelines and what your protocols look like, then you are in a much better position. And then we get to telehealth. Telehealth has exploded. It absolutely has exploded. And you've seen a number of facilities that have just rapidly, just out of necessity, had to implement telehealth where they maybe never really used telehealth all that much before. So it is definitely now presenting its own set of challenges, and I think there's a lot of folks out there that are really struggling with OPPE or FPPE in the setting of telehealth, or even if you're not Joint Commission accredited and you're accredited by one of the other accrediting bodies, you've got the same type of processes that you have to have in place to show your ongoing quality monitoring, and that's really difficult. What do we measure? How do we collect data? What does it look like? Is it the same data that we collect for an in-office visit versus a telemedicine visit? Does it look far different? What do we do for our surgical specialties that are now essentially doing their office hours by telemedicine instead of having patients come into the office? So just there's a lot of questions out there right now. So as of now, there's actually no uniform measurable quality and outcome standards for telehealth, which I find kind of interesting just because telehealth has been around and there's been a lot of services that have utilized telehealth for a long time. We look at like stroke medicine is a great example where teleneurology to assist with strokes in the ER or otherwise has been around for a long time. But there's really no actual standards or metrics that have been identified and have been sort of set as the guideline or the kind of the gold standard. The National Quality Forum attempted to kind of start this discussion a while back, and they produced this big 80-page report, which you can find online if you want, and it gives some suggestions of what we could look at. So some of the recommendations for measuring telehealth. It's kind of in these 4 specific areas. So patients' access to care, the financial impact on patients and clinical providers, patient and the clinician experience, which is a big one, especially when we get back to reimbursements, and effectiveness of clinical outcomes in operational systems. So there are some ideas out there, and actually MD Review is currently working on developing some guidelines that could be used as a framework, because I do think that this is a challenge that so many of our facilities are facing today. So I found this to be really interesting. this is information about telehealth and what they had done looking at the healthcare quality metrics. And if you look at these numbers, patient satisfaction, huge increase with telehealth. Medication adherence, again, you've got a big increase. Health compliance, health complications, there was a big decrease with telemedicine. What we found is telemedicine gives access, provides access to healthcare to a lot of people that maybe struggle to get it otherwise, right? They don't want to have to drive 30 miles, or they themselves are not equipped to drive, so they always would have to set up a method of transportation to get to a doctor's appointment or whatever it might be, and telehealth allows them to be able to have access to that doctor appointment to manage a complication or to get a prescription refill or a new prescription, whatever it might be. So we see a big increase in patient compliance, a decrease actually in medical errors, and access to care is much greater, and diagnosis accuracy as well. So I thought this information was really easy, and I mean really interesting to look at. And I do think that what we'll see now, again, telemedicine, we sort of had to go there because of what was happening with COVID-19. But I really think that we're not going to see it just drop off. I think we're going to see that increase stay in a lot of areas. And so this is just really, I think, great information to support that. So there's clearly a lot of benefits. But how does the hospital or the clinic, or how do you measure success, right? So now you've implemented this, and now how do you determine if it's working? And maybe you're considering, should we keep it? Do we keep sort of this high level going, or do we try to bring people back into the office? So here's just some metrics to consider. And you can look at the amount of time, so how much time is spent with a provider on a phone or on a video with a patient, number of visits. Are we seeing more patients? Are we able to see more patients with telehealth than we could before? Accuracy of diagnosis. So what we're doing via telemedicine, are we accurate in our diagnoses? And what are some of the chief complaints? What are we seeing most often? Is it our primary care providers that are just dealing with sore throats and things like that, or are we seeing other types of complaints coming through? Quality of the service and the technology. So again, how easy is it for the patient to utilize the service, which again leads to that whole patient experience, patient satisfaction. Patient retention is a good one as well. Time and travel saved. This is for both the patient as well as the provider, quite frankly. So how much, what are they able to save in time of traveling to, the physician's office, sitting in a waiting room, etc. Treatment plan adherence. You have patients that are complying in greater compliance with their treatment plans than you did before, and then referrals. And so are we still, this is a great metric to look at, are we still referring to a specialist where necessary? Do we have a good process in place and a guideline in place that says, here's what we can treat via telemedicine, and once a patient kind of gets to this level, then they do need to be referred to be seen in person. So these are all great, some of the metrics that you could consider to look at. So again, the need for safety, just overall public health, is what has driven this huge increase in our use of telehealth. And like we said, we're seeing that its capability to address everyday medical needs. I think will probably make it part of our lives for good and for ongoing. Joni, you talked a little bit and referred back to rural health, and I do agree with you. I think that rural health has benefited from this increase in telehealth. Oftentimes, as the name implies, they're in areas where people are quite a distance away from their caregiver, and it's much easier for them to be able to operate on a laptop, a tablet, whatever it might be, to be able to go to the doctor rather than making that 45-minute drive to the doctor just to get a checkup. So again, I think that helps when you're looking at maintenance of ongoing chronic diseases like diabetes and things like that. it's really helpful for the physician to be able to have greater interaction and more consistent interaction with their patient, and it just improves their, their overall outcomes. So, but the bottom line of all of this as it relates to connected health or virtual medicine and peer review and quality is that provider competency and clinical quality remain paramount. So it is our, it is our collective job to ensure that the providers within our institutions are currently competent to perform the privileges that they've been granted, and that remains the same. We have to make sure that we have all of these same quality measures in place, and that we're tracking these metrics to ensure that our providers are still competent and that they are providing good quality of care, even though it's being done over an internet connection instead of live and in the office. So quality and patient safety always come first. And again, I think that we look at some of these metrics, and I do think it's important that there's a lot of the same information that must be present in a virtual visit versus an in-office visit. And so, does your review of systems, is there a difference in that versus telemedicine versus in-person? And I don't think there is. I think we have to make sure that we're still doing a full, a full review of systems when we're talking with the patient. The difference is just how do we capture that? And is it something that we, do we go ahead and we do a survey on the front end, a questionnaire where they fill out a lot of information and we capture that information that way? So that how we get it may be very different, but I think documenting the same information is vitally important.
And then also just kind of a funny there, Sharon, to share. We were talking about this the other day, Sharon and I had one of our customers say, okay, we had a virtual telemedicine visit and the elderly lady had a rash, and she pulled her clothing off to show the doctor the rash virtually. So we have to think about that. How do we need to preface these visits for the patient to say this is what you're expected to do or not do virtually versus what you would do in a patient exam room? And then if we do want to look at something on a person's body virtually, do we need a witness on the virtual medicine call with us to do so? Or, some of that is going to change a little bit. And even though it was humorous, it wasn't a big deal. I mean, she wasn't exposing any really, delicate areas, but still, just pull her shirt off her shoulder. The nurse told me, she said, we were a little concerned that it was going to go further and we didn't know what to do and it was virtual. So, there's things like that are going to come up on these virtual visits that you may or may not need to include in your policy.
And I think that has to be, that we have to have really strong policies about what can be done in a virtual visit, and at what point that patient needs to be told that they need to be seen in person, that they're, what they're asking about or what their diagnosis may potentially be is something that extends outside the scope of what telemedicine
and comfort and expectation for the patient. What am I to expect on this virtual visit? What is my role here? And, what can I expect to happen? Because a lot of people, 50% or more of the population aren't used to seen their doctor online. So delicate things like, my mother right now is in hospice, and I read in one of my other webinars that we talked about where someone told a patient's family, that their father was going to pass away in a virtual visit. And, we might need to consider those things. That's something we want to do. So.
Well, and like I said, we at MD Review, we're working currently to try to put together a framework of some guidelines for quality metrics and what you're looking at and what's important to document and capture and flag, because I do think it's all new challenges for everybody. So we can work together to make sure that we've got the information that we need. I think that's it. So I'm going to go ahead and shoot back to Alex here to wrap things up.
Thank you, Joni. Thank you, Sharon. Really appreciate it. We have just a couple, like about 5 minutes, so I'll let you go ahead and submit your questions. Just to let you know, we have recorded this session. The recording will be emailed to you, if not later today, by tomorrow at the latest. You will also receive a copy of the slides with that email, so that will be available to you here very shortly. Again, if we can't get to all the questions today, we will answer those via email to you individually. Just a word about Simpler, if you're not familiar. I know many of you are current customers, but in case you're not, we do have a pretty robust suite of solutions for provider management that involves credentialing, privileging. We have a quality review suite, and we do have a new solution that's built around patient safety and incident management. So if you have any interest in any of those, feel free. You can email us at the sales email, or we also have several contact us options on our website. The other thing I wanted to mention before jumping to the Q&A is that we do have another session this month on the 16th, which is coming up really quickly. Team MedGlobal will be talking about practitioner competence evaluation. So if you're interested in that, please visit the events page on our website, and there's a link there to go ahead and get registered. All right, so let's go ahead and jump into questions. Joni and Sharon, most of these so far are just compliments on the content and that it was informative. There have been some questions about the CEU certificate. So with the CEU certificate, that will be linked in the email as well. So you'll be able to access the slides, the recording, and your CEU certificate all from that one email. And it looks like that's it in terms of questions. So I don't see any new ones coming through, but again, don't hesitate to reach out via email. We are here to answer your questions, and I'll give you a couple of minutes back in your day. Thank you so much.
Thanks, everybody.
Thank you. Hello.
Do we want to stay on?
I would.